Good morning. I think it's still just morning. My name's Kristen. I'm a clinical nurse specialist working in the Store Liver Centre at Westmead Hospital. My work is focused on the implementation of a model of shared care which we hope will improve the outcomes for patients with hepatitis B and reduce the late diagnosis of liver cancer and put a solid model in place to work toward an overall prevention of liver cancer for or hepatocellular carcinoma or HCC. Some acknowledgements first. So Professor Jacob George, Dr. Monica Robertson and Monta Paulo, who I work with quite closely and put in a considerable amount of time towards this project alongside their other jobs. And I'd also like to acknowledge the 3-year grant funding for the Hotter West program, which is provided by the Sydney West Translational Cancer Research Centre. So a bit about the background. So chronic hepatitis B is the most common cause of liver cancer internationally. Almost 800,000 Australians die from hepatitis B infections every year. Recent migration from high hepatitis B prevalence countries has increased our local incidence of chronic hepatitis B and HCC. Unfortunately, many people are unaware of the link between chronic hepatitis and hepatocellular carcinoma, and HCC, or hepatocellular carcinoma, is among the top 10 causes of cancer death in Australia, with about 80% of cases attributable to chronic viral hepatitis. And these graphs, which were produced as part of the Cancer in New South Wales Incidence Report, show the sharp incline in HCC incidence between 1973 and 2009, the number of new cases for male and female. And this clearly illustrates a cancer which is not being well managed and is a real relevant challenge for us. HCC has a greater than 85% 5-year mortality rate. With the increasing incidence, as seen on the previous slide, we also see an increase in mortality. The mortality rate is unacceptably high and late diagnosis has a big part to play here. Our program focuses on the impact chronic hepatitis B is having on our local community. It's the main cause for rising HCC rates in Western Sydney, where the greatest burden of disease is among people born in hepatitis B endemic countries, predominantly Southeast Asia and Africa. The red areas highlight the high HCC incidence, which is our focus area. Every person diagnosed with chronic hepatitis B requires guideline-based care. For some, this is once-a-year monitoring, and for others this includes 6 monthly HCC surveillance with abdominal ultrasound and AFP. Basically, no one should be living with chronic hepatitis B that's unmonitored. However, as you can see from the graph here, only 18.5% of people diagnosed with chronic hepatitis B in New South Wales are receiving the correct care. This gap is inadequate care is contributing to the late diagnosis and poor prognosis for people diagnosed with HCC. Although 60 to 80% of HCCs are preventable with antiviral therapies, multiple barriers exist in the diagnostic and treatment continuum. General practitioners are usually the first point of call for people with chronic hepatitis B. A large number of patients we engage with in Western Sydney do not speak English as their first language, and for many, English is not spoken at all. They usually engage with their GPs who do speak their key language. A study in 2011 at St George's Hospital conducted a survey with 120 GPs, and they found that 22% did not recognise that HCC was a complication of hepatitis B, and 20% were unaware that there was any treatment for hepatitis B at all. So key challenges to HCC prevention. Our key challenge is, how do we get more people living with chronic hepatitis B tested, cared for and treated to prevent the deaths from liver cancer? Oh, I keep hitting the button, sorry. Okay, so our aims: to provide a high quality, effective and supportive service to general practitioners in our local community in order to increase the level of understanding surrounding the relationship between chronic hepatitis B and liver cancer, and through this increase the uptake of antiviral therapy and decrease the overall burden of end-stage liver disease and liver cancer. So we developed a model of shared care, a model that includes a GP, a nurse specialist and a hepatologist or gastroenterologist. Our model of care relies upon a strong link between health professionals working in the primary and tertiary sector, sharing a common vision on ways to achieve desired healthcare outcomes. The model was developed to support the local general practitioners to deliver optimal care to their chronic hepatitis B patients. It ensures GPs are supported by the clinical nurse specialist in triaging the patients with chronic Hep B and referral to local liver specialist as necessitated, according to our current management guidelines. Chronic hepatitis B has several phases, and at times the virus can be deemed complex due to the viral activity. The goal of the model is to channel the non-complex patients into the GP's care and ensure those requiring a higher level of surveillance are referred to the specialist. The nurse specialist holds the key role in ensuring that the patients are referred to the appropriate care, and management thereby freeing up the long liver clinic appointment list for more complex cases. How does this work? So the patients with chronic Hep B are enrolled into the service with a specific referral form, and on the referral form we collect all of the relevant pathology and results that are needed to see what phase of virus they're in. Patients who are deemed non-complex are maintained under the GP's care with ongoing support from the nurse specialist. Patients deemed more complex are referred to the specialist clinic, and once they're stable they're sent back to their GPs. Patients receive a letter which is generated by our registry, which reminds them to see their GP every 12 or 6 months. Their pathology and radiology results are reviewed by the nurse specialist and discussed with the specialist clinician, and this is an opportunity, or a key opportunity, to identify any changes requiring a higher level of surveillance, allowing for any potential complications to be identified and treated early. GPs are now also, if they've had training, able to prescribe the S100 antiviral medications, and once a patient has been initiated on treatment with the specialist, they can go back to the GP for their further management. So far, our results. Our program was started in March 2015. 120 patients have been enrolled and triaged appropriately according to guideline-based care. All of these patients are now on the correct pathway for their chronic hepatitis B and are receiving the HCC surveillance as appropriate. This has been initiated in 2 large GP practices in Western Sydney. 70 patients have been assessed in the nurse-led community fibroscan clinic, and 10 patients have commenced on antiviral therapy and been successfully sent back to their GP for ongoing care. As part of the program, we also have a strong focus on increasing knowledge for GPs and for the community. In April this year, we conducted a large educational evening for local GPs and their practice nurses, and 90 people attended, and we had 3 local specialist guest speakers. We also run regular patient group education sessions with about 20 patients each time, and the topics focus on chronic hepatitis B, HCC, treatment, taking charge of their treatment, and living healthy. So far, the results and feedback have been really positive from the patients. We've developed several in-language resources, so bearing in mind that predominantly the patients that we're dealing with at the moment are speaking Chinese, and I work with a translator, so having resources in language is really important. So this one here is a pathway that we give our patients available in Chinese and English, and it just explains to them what the program is, what they should expect from the program, and each of the key health professionals, what their role is and who they can go to for help. Fibroscan plays a big role in being able to offer this to the patients in the community in their GP setting. So it was really important that we were able to give them something in language to explain what a fibroscan is, how it works, that it's not painful, what we intend to do with the results, and why they need to have it done, basically. And we've just launched a program-specific website which has a section for the community and a section for the health professionals. And this gives them information about the program, but it also gives them more information about chronic hepatitis B and HCC and links to additional information. So implications. Shared care model, as I said, has has been piloted, and it's led to timely referral, monitoring and surveillance for the 120 patients, thereby assisting in the prevention of HCC in that population at risk. Those 120 patients have now received evidence-based care for their chronic hepatitis B diagnosis. Implementing a system to allow for tracking of patient results and HCC surveillance requirements means patients are engaged in a program that ensures cancer screening is correctly implemented. This model also empowers GPs in the process of caring for their patients with chronic hepatitis B in an environment which the patients feel comfortable, and encourages the GP's involvement in the antiviral therapy as well. And finally, where do we want to go from here? Further growth of the program. At the moment, as I mentioned, we're just in 2 GP settings, so the idea is to branch out. Further expanding our community engagement and providing more education to the community, and increasing their knowledge of hepatitis B and liver cancer. And of course, evaluation of our impact on the timely diagnosis and treatment of HCC. Thank you.
So Kristen's been really slick, and there is time for questions for Kristen. So has anyone got one? I've got one. So this is an interesting example of the system actually starting to be aware of people before a diagnosis, which is not typical to the cancer system. Mm-hmm. And I just wondered how you're finding that interaction, or do you not really touching the cancer system yet?
I'm not really touching the cancer system yet. I suppose because our patients are, because they're registered onto the program, they have a strong link with the liver specialist, so we're able to identify any changes really early, and anything that we identify that requires that higher level of surveillance goes through the MDT at the hospital, so they're linked into the cancer service, I suppose, quite early on, if necessary, and we have all of those things in place for them. Does that answer the question?
Yeah, that's good.
Yep.
I know there was some, when the study was looking at being funded by the Sydney West, that there was a question about whether it actually fitted into the guidelines for funding out of a cancer research program, when in fact it's cancer prevention. So it's an interesting, so great work.
Thank you.
And remembering that liver cancer hit top 10 of causes of cancer deaths in the latest statistics. So really good. Thanks, Kristen.